Just while we wait for a few people to come back into the room, I'll just say a few words about the mental health practice networks, which are designed to help people, help clinicians to educate each other about how to work together, and also to further their ongoing professional education. We're very happy to support this mental health practitioners or professionals network. Let's get that one mixed up. As we see a very large amount of unmet need for support and treatment around personality disorder. And as people were talking about fashionable post-traumatic stress disorder, there is research that shows that the family and carers of people with BPD can have PTSD at the rates equivalent of some of those veterans. But it's a different kind of stress. It's a stress that comes from not being able to find the right kind of support to assist you for extended periods of time, and that is very stressful and very bad for the health. But obviously it's not anything that's the fault of the person with the issue. It's because we are not that great at either prioritising relationships in our community or in delivering care that requires an extended period of engagement. We're actually much better at acute care on the model of a garage, for example, where you hear a knocking in the engine, you go give it to someone, they give it back to you all fixed, Bob's your uncle. As a broken leg or twisted ankle, that will do. But if you've got something complicated, something long term, something that requires as the only means of achieving recovery the building of an empathic relationship, that takes time, and time is money. So our system is not that great at delivering it yet. But as we always say when we're doing systemic advocacy on this point, we can never get to cost effective unless we get to effective first. And what they're doing around this stuff isn't effective. So of course it's just a huge waste of money. And until we get more clinicians who are able to deliver the care for the period of time required to allow people to really address their problems, we're going to be continuing to waste money instead of actually providing the support that could achieve a result and achieve great economic returns for the investment made, it should be said. So, although we're still waiting for Shay, I think everybody has had the opportunity to look at these case studies. So I think I'll ask Mitchell perhaps to give us a little overview, and then we'll maybe get each speaker's take on it, and then we will be open to questions. Maybe just a brief. You don't have to read. How long do you reckon it take to read the whole thing?
And so fast I read. Let's see how we go. Has anyone not had the chance to read the case study yet? Okay, so everyone's one person at the back. Mm-hmm. Read fast. So I've tried to put a case study together based on a hypothetical young female, Bryony, who was recently discharged from a hospital after being admitted after having an argument with which her admission was precipitated by an argument with her boyfriend. She's been admitted several times before. She has difficulties in four domains of life, and all of these difficulties reflect the diagnostic criteria in DSM-5. I thought that what we could do tonight is perhaps, as clinicians or carers or people involved, is to pick out aspects of the case study that people would most likely to speak to or ask questions about. Clinicians, perhaps you might want to offer what you might start with. So Bryony has issues in these four domains. However, she's not in immediate danger. She is motivated to address any of the concerns that are outlined here, and she can attend weekly sessions for a year. She's unsure what to focus on, so she asks your advice. The two questions I would pose to everyone here is, where would you start? And what insights or skills would you want her to leave therapy with? If you're not a therapist, perhaps focus on maybe a relationship that you would have with Bryony. What would you want your relationship to look like, or what would you want her to leave your relationship with? that make sense, or should I read through the case study?
No, that's good.
Cool? Okay. Would anyone like to go first?
Why don't you give your take on it
Yeah,
to start off?
sure. I think following on from what I talked about in my presentation, I suppose more and more in my work I'm focusing more on the relationship that I have with clients. I suppose I came out of university with a lot of skills. I was trained in CBT, and that worked well for my anxiety, because I felt like I could, if I knew everything, if I knew every technique in the world, and I could go in and then nothing will go wrong. And then human beings are a lot more complex than that. And also I kind of got into I consulted the research literature, which suggests that really it is the relationship, it's the bond, the therapeutic bond that you have with the person that really predicts them getting better. And I think that was really reflected in what you said, Shay. So I think in saying that, I would go with, where am I? So if we start in the affect emotion section, so Bryony's emotions are intense and are remarkably sensitive to things in her environment. Her mood can flip on a dime, particularly in response to people and relationships. She can go from being relatively content to intensely distressed for hours at a time when triggered. You remember an example of this in your work with her. She became visibly upset when you announced the end of the therapy hour. So for me, I'd probably start there. If I noticed her, I think I'd go on sometime in the rest of the case study. If I noticed a sense, perhaps she felt rejected by me ending the session, I would really latch on to that. I'd say something to the effect of, Bryony, I noticed that when I announced the end of the hour, that you winced. I'd like to get some information about that. How are you feeling about that? How are you feeling about me right now? So I'm very interested, especially in the last several months, and I think for the rest of my career, I will be focusing intensely. I'll be focusing on the relationship. I'd be really interested in her feelings about me, whether she's feeling understood by me, and whether she thinks therapy is progressing, and whether she feels, as I say, how she's feeling about me directly. Because I think from there, then I can intersperse all of my CBT skills. But yeah, I think I'd start with that, and I'd attend to that as the therapy went on too. That's not really something I'd just focus on in the initial sessions. I'd be doing that.
So maybe we go to Shay next.
I did speak to somebody just a moment ago about the impulsivity and the effects and the emotions. Often, as I mentioned earlier, the barrage of questions that people who are seeking help often get can be extremely frustrating. And the joke that clients and patients have is that we should have a card in our wallet or in our purse that has the answer to all the questions that you ask us, because it can be really horrible and really frustrating to repeat yourself over and over and over again. So if we snap, there's a reason why we snap. And then people might say that, there's anger issues there, and that's part of your diagnosis, and we need to work with that. So, probably I have an air of caution when it comes to a lot of things here. I'm very skeptical, and I think there's much more to a lot of this than meets the eye.
Do you have a good tip for engaging someone who might be really ambivalent to start with?
Well, I did say earlier that, building a relationship is important. You don't really need to ask a lot of questions, but, you can actually talk about something else. You can actually tell a joke. You can actually kind of talk about something. And I don't mean... And it's got to be authentic too, because often people say, you have to build rapport, and you might ask about the weather, or it's a hot day or something. But rapport is like, I don't know. I think people really misunderstand what rapport really means, and I think there's a real value in actually slowing the hell down with your agenda. Slow down. You can actually feel silence and be comfortable. You can actually give space to people to think, because I know that people are under time restraints, and people feel so much pressure to try and fix people. But when you slow it right down, people can actually start to kind of sit with this and become comfortable and relax, because then you can actually start doing things. I think the hardest thing when it comes to, working with people is the agenda, the professional practice, the procedure, all the things you have to do to fix people. That can really damage things.
Rebecca?
So with the case study, looking back at what I was talking about with over control and under control, because of the impulsive behavior and some of it sounds mood related, this would be someone who you would practice standard DBT with. And based off of what Mitchell was talking about, obviously you would want to establish rapport with the client. And what I would really want to go to next is understanding what she means by some of her some of these words that she's using, like impossible to control, or snapped, or 0 to 100 instantly. Her emotions took over, or the anger took over, because some of these words and phrases that she's using might be something that she's heard in her environment to describe her behavior, and trying to really understand what that means to her and what are the things that she actually wants to work on, instead of using these vague terms to describe her behavior that might have been from an invalidating environment.
Are there any indications in the case study that tell you whether she's over or under control?
So obviously you would still want to assess, but the impulsive spending, using an entire week's salary, that would be like something. So someone who's overspending might maybe plan to buy 2 shoes after the end of the week, after certain things that are happening, but they wouldn't actually go into debt or use all of their money. That would be more impulsive. And then the multiple hospital visits, because it's public again, that's what you would look at.
Dr. Corner?
Yeah, look, I put up a few points earlier, so you might have seen those, and I commented that I'd be interested in listening. I'd probably set things up along the lines that proposing that we have several sessions to get a fuller idea of what's going on, perhaps 3 or so. I'd try to be clear about how long those sessions would be, so that from the beginning you're setting up a framework that is going to be viable for you as well as for the patient. The point Shay makes about questions is very important. I think, when your interviewing is based on questions, you're constantly putting pressure on the patient to come up with the answer. It actually narrows thought rather than expands it. Often making a statement which expresses interest, or it sometimes really just is very simple, creating more space, maybe picking up on a phrase that's been used. People might refer to that as Rogerian sometimes, after Carl Rogers, but and that kind of intervention can be parodied, but it is actually very useful and very simple, and it actually promotes connection. Over time, if there's at the end of the 3 sessions, I'd want to share something about what I've understood, and see if it makes sense to the person, see if we've got common ground, if we're talking the same language, whether there's an agenda to pursue. It could be that other things are important, drug and alcohol issues are raised by this case. An intervention that relates to that could be important. Working on, you can see that she has problems in relationship, but at the same time relationships are important to her. And, she's also maintained a relationship, much as it may be on and off. Working on the relationship may be an important thing. So depending on what happens in those initial sessions, my formulation might vary a bit, depending what I felt was, the main concerns at this time. I guess there's a sort of longer term aspiration if we proceed and engage in therapy over a year or so, or whatever time it might be. I think it's very likely that when people learn to feel at home with someone, ultimately they start to feel more at home with themselves. And when that starts to happen, that's really addressing a core feature of borderline personality disorder. One other point, I wouldn't be rushing to diagnosis. I'd want to see what the patient's understanding of their issues are, but on the term complex post-traumatic stress disorder that's been raised, personally I actually prefer complex traumatic disorders, and the reason for that in my case is that I think PTSD was originally described in relation to a single event. And what we're generally talking about in relation to complex trauma is not a single event. It's relationships, it's the environment in which someone's developed. Often there have been multiple events and relationships that have really had an effect on that person's developing capacities. So I think complex trauma, in my mind at least, pays some respect to that.
So, very interesting takes on the case study, and I think it is really about perhaps the clinician not having an agenda to fix someone, to get them in and out the door, but maybe working with them to detect what their agenda is. Because from a carer's perspective, I can say that once someone's actually prepared to engage with some therapy of some kind, the carer's like 90% home because they've got something to happen. Whereas often the difficulty is getting someone to want to start. And that can be because that person feels that they are having an agenda imposed on them. And of course the natural reaction is to resist. So I think that those comments are very much driving in that direction. Once we start to work with the person to help them solve the problems that they appreciate in their lives, and we start to get that buy-in and enthusiasm perhaps to make changes. But that's just my inexpert opinion, although people do very well with us. So do we have some questions for the panel on this or any other subject?
Just a comment really. Shay, you've talked about how frustrating it is, to be bombarded with questions, and I can certainly understand that. However, I work with staff in mental health facilities, and I know the incredible pressure they're under to fill in huge amounts of forms and to identify multiple risks, as they're called. The risk of suicide risk of aggression, risk of self-harm, risk of absconding. There's about another 6 risks. Plus, are there any children at home? Are they at risk? There's all of these areas that they are obliged to fill in. So there's a sort of a contradiction in the system there, isn't there? Because you're finding that, oppressive, and I can understand that. The staff also, I think, find it oppressive because they're always very busy. The staff I deal with anyway, they're usually very busy and they've got multiple people they're trying to admit and assess. They've got all these forms which they say to me is really hard I want to engage with the person, I want to form a relationship with them, but I have to fill in all these forms or I'm going to be in trouble. So there's an inherent problem there, I think.
And ironically, it interferes with the one thing that will probably predict lower risk on all of those things.
Yes.
Yes, no, very much an issue, and we have great hopes for the electronic medical record, but ultimately what seems to work very well in some systems is having one contact person that consistently liaises with the person and the health system so that you get past some of those issues, but that would require quite significant surgery to the system we've got. But definitely there's things that we can try to do to minimise the need to repeat.
I was a part of a review of the ministry and the commission in the last year from somebody with lived experience, and it was something that I raised significantly, that their staffing, what they're looking at in their staffing, and who they have working, are engaging with patients really needs an overhaul, and because they put the primary focus is on nurses and psychiatrists and things like that. But I think the weight of expectations on a lot of the professionals that are working with people with mental health is unfair. So I think a lot more people need to be brought in. For example, I was telling them that you are not allowing any people to come in who are doing therapeutic training, or who are doing counselling training, or even just to be somebody to listen to. You're putting up the red tape to not allow anybody because of the risk. I said, if you kind of break down those barriers and allow people who are training to be psychologists, training to be counsellors, training to be mental health professionals, if you allow them just to come in, just to listen to somebody while other people are doing all the forms and all the paperwork, then they can actually sit down and actually relate to somebody, or build a relationship, or be heard, or somebody who's even trained at something as simple as active listening. That's all you need, somebody to come in and give some active listening to people who are not being heard. Because even as a patient, I was saying, nobody's listening to me, and they said, here are your meds. And I said, look, the Black Dog Institute is out there. Why is nobody talking to me about all of the stress I'm going through? I can't handle this. And they said, just take your meds. So I think the approach, we need to kind of really look at systemic change. We need to bring more people in just with those basic skills to be able to even just validate, acknowledge the person going through those experiences. And I think the system is unfair, but we need more people involved, because it needs to be holistic care and not just a medical model.
I was wondering if, like, in relation to that point, if there's any plan to sort of have more training in the conversational model, because I just feel that the conversational model has incredible strength and richness in that kind of exactly the stuff that Shay's talking about, and I wonder about training in the conversational model within sort of public mental health.
Yeah, look, we're trying to develop it, although I would have to say at the moment we're struggling with within our own area for some of the reasons that have been mentioned. I think that the systems are risk averse. Defensive practice is encouraged. I also personally think there's a bit of an issue around technologies that distance us from actual contact with people, and we seem to all, I think, be spending more time in virtual spaces and less in direct clinical encounters. That's certainly an increasing tendency in the time I've been in practice within the public sector. So I'm not quite sure what the answer is. I mean, we do think the conversational model has strengths. It probably hasn't been as effectively marketed, and it is essentially a psychodynamic model, so it's a little bit more open and focused on the individual rather than the diagnosis. I think it's also a transdiagnostic model, which was mentioned in relation to DBT. But DBT and I think MBT have been very effective in marketing and training people over short periods, so perhaps that's something we need to learn from.
We've got limited time, so I'm going to go to the questioner at the back, and then I might get each of our panellists to make a final comment. We might have to wind up, but I'm sure that they'll be here for extra chat for a few minutes anyway.
I'd like to just advocate for as many mental health professionals going into their own private practice as I have, and you don't have to do it like I have, but I have the freedom to see people for 1.5 hours, and there's tea, there's coffee, there's biscuits, there's Kit Kats, and it's a comfortable place, and there's a dog, there's a practice dog. Now I can do all of that because it's my practice. And so, get into private practice. Just a comment.
Thanks very much. What you might
Thank you for all that's been prepared and given. My question is to the people who are operating clinically on the panel. How and when would you choose to involve family and carers in progressing the health of the person you're looking after?
Perhaps one comment in this area, you know, sometimes families can be seen as the problem. I think in practice they're typically the major support for a lot of people with PD diagnoses. So considering involvement of the family is very important. At the same time, I think, at least with my practice, we're working with adults, so any involvement of family would be very much a matter for the patient to decide ultimately, I think, but I think it's something we should be open to.
So with DVT and also RODVT, the family, like Anthony was saying, is that it might have created it might have been the invalidating environment that led to BPD, or they might have had the self-control and the reinforcer behaviors to put more self-control from the parents or the family involved. And it also, if you're able to bring in the family to change or to teach skills to the entire system, DBT has multifamily DBT, so the parents or partners come in to learn the skills just like the client. And Radically Open DBT just came out with a manual to do that as well. So teaching the entire family the skills rather than just the client, because we don't put all the blame on the client. It's not possible, right? We learn all of our behaviors, all of our thoughts, all our emotions through experience. So.
I wouldn't have anything to add to that. I work with adults mainly, so I think if I was to involve the family, as Tony says, I think it would be the discretion of the client, really. Yeah.
Probably the way I would probably involve the family would be to probably use people with lived experience with the diagnosis to maybe help inform the carers as to what's happening for the person with the diagnosis. I probably wouldn't have them directly involved in the person's treatment and care, but I would advocate to inform them as to what's happening for the person, because I think they might feel lost, hurt, distressed. I think there's a lot of things that the carers might feel, but I think that there needs to be kind of a separation of treatment, and I think that it's really important to kind of inform the carers as to what's happening for their loved ones, because it might be a very distressing and overwhelming time where they kind of feel they don't know what's going on here.
Thanks very much. And just coming from a carer organisation, I would say that I think that BPD is not an illness where a person generally loses all capacity for making decisions, and so we should be respectful of the decisions they want to make, generally speaking. However, I would say that there are some times when the carer can inadvertently not be helping the situation, and sometimes it would be very appropriate to have a couple of joint sessions if it's necessary to work on that relationship so that they can understand how they can help more, or at least not impede progress. But having said that, obviously ultimately we need to respect the autonomy that we're trying to build. So I think that we've come to the end of the time allowed. It's been a very interesting discussion. Would our panellists like to make one final comment before we wrap up proceedings?
Really just thank you. I've enjoyed it as well. So look, there's hope. I think we shouldn't minimise the difficulties we're talking about as clinicians. Whilst I think in my first slide I referred to it being an unfinished story, we shouldn't think we've come up with all the solutions. We haven't by any means.
I just wanted to thank y'all for letting me speak here tonight about the new treatment, and I think the more we learn about our clients and the more we learn about mental health in general, I think we'll get more effective with our treatment.
I'd just like to say thank you all for coming. I think I'll just reiterate some of what I said in my speech. I think there is stigma around BPD. I think a lot of it's unfounded, and I don't think it's fair. I think in working with people who have some of these traits, I think the passion is the most important thing, and I think that informs a lot of the work. And I think I would be doing good as a clinician if I can stay true to if I can stay true to that, I can stay connected to that passion and connected to wanting to build and maintain a strong relationship with them. Sure, I'm just giving advice to myself, really. Take it if you want it. It's more for me. But yeah, thank you for coming. Thank you for having me.
My friend and colleague on the panel mentioned sharing the language and learning the language of the person who's going through this is really important. And I also think that would help break something that actually I don't know if I've mentioned yet, but the power dynamic in the relationship is a very strong one with BPD. So breaking that down is vital to actually having a relationship where you can have effective change. And I feel by looking around the room and seeing the nods and smiles and the eye contact that people have really taken it in, and I want to appreciate that. Thank you.